My name is Dan Gelinne with the UNC Highway Safety Research Center. We wanted to thank you for joining today's CSCRS webinar, Building a Motor Vehicle Crash Injury System of Linked Data, Lessons Learned and Questions Answered about Pedestrian Injuries. Before we get started, I'm going to give a brief overview of CSCRS to those of you who aren't familiar, and just cover a few housekeeping items. The Collaborative Sciences Center for Road Safety is one of two national centers with a dedicated research focus on transportation safety. And our mission is to accelerate progress in reducing injuries and fatalities by utilizing a systems approach to bring perspectives from planning, engineering, public health, data science, and robotics to the road safety field. CSCRS is comprised of several departments at UNC Chapel Hill, along with our partner universities that you can see listed on the opening slide. For today's webinar, I'm glad to welcome two panelists. First, Dr. Anna Waller, a research professor and director of the Carolina Center for Health Informatics in the Department of Emergency Medicine at UNC, and Dr. Katie Harmon, a research associate at the UNC Highway Safety Research Center. So you'll hear from them shortly. I have just a few housekeeping items to cover briefly. Participants, note that you'll be muted during the session, but you will have the ability, and you do have the ability, to submit questions via the Q&A function here in Zoom webinar. We'll have about 10 minutes at the end of the webinar to handle questions that you submit with our panelists. The session is being recorded. It will be posted later on the CSCRS website. And we encourage you to use the speaker view option so you can see the slides and the layout that will look best for this particular presentation. So without any further delay, I'd like to go ahead and turn things over to our first speaker, Dr. Anna Waller. Please go ahead and get started.
Thank you, Dan. I am trying to find the slide that was right there, but now it's not. Hang on.
Sure.
I am so sorry. I had it and now it's disappeared. Here we go. Got it again. Okay, can you see my slides?
Yes, it looks good to me.
Okay, great. Thank you so much, Dan. I do apologize for that. I also want to apologize. The camera on my laptop does not work, so I am here, but you'll only see a picture of me in terms of the participants. I'm Anna Waller, and Katie and I will be presenting to you today. And I want to start by acknowledging the funding for our work, which came from both the CDC and our North Carolina Governor's Highway Safety Program. Some of the data that we used was obtained under a data use agreement, which requires this disclaimer. Basically, everything we're going to present represents our own work and our own interpretations. We're going to start by talking about why we think data linkage is important, including an overview of our data linkage work here in North Carolina and some of the things that we've learned through this work. We'll particularly focus on some of the results related to pedestrian and bicyclist injury. We're also going to spend some time discussing a few of the challenges that we found along the way. So I'll start by briefly summarizing what was more than 5 years of work here in North Carolina. The goal of our data linkage efforts has been to establish a statewide integrated motor vehicle crash injury surveillance system, which we've called the North Carolina Crash Injury Surveillance System, or NCSYS. We believe that such a data system has the potential to improve the analysis and evaluation of transportation safety outcomes, to expand research opportunities, and to inform policy and programs. Most data sources on their own are limited in scope, but by linking with other data sources, we can create richer data to help us answer broader questions. So that was some quick background on why we're doing data linkage in North Carolina to address motor vehicle crash injury. This work has led to a variety of products, and these are posted online at the site that's given, and I think that's going to also be put in the chat. And now I'll share a bit about some of the lessons we've learned through this work. One thing that's clear is that collaboration is essential. Not only do we need a diverse project staff representing an array of disciplines, We also need buy-in and important input from both data owners and data users. Community groups and advocacy organizations should be involved to ensure that the products of an integrated data system are useful for their prevention efforts. And finally, without funders on board, the work simply won't happen. And this is the diagram of the many important groups that influenced our work with NCSIS. A very important lesson learned is that the quality of data linkage is directly related to the quality of the data being linked. It's a classic garbage in, garbage out situation. On more than one occasion, we had to back off from a planned linkage source due to poor quality data. Sometimes we were able to return to that data source at a later date after the data quality and completeness had been improved. Data quality also impacted the data elements that we could use for our linkage. An important byproduct of our work in North Carolina was that we created standardized data documentation for a dozen potential sources of data for linkage. And that's the list here. And the documentation is available online. Again, we'll provide that link in the chat. And on the right-hand side is just an example of what some of that documentation looks like. A huge lesson learned for us was that we could achieve reasonable data linkage results through a variety of linkage methods and with very limited identifying information available. We have no unique identifiers available between our data sources, so nothing about the linkage we do in North Carolina is straightforward. Through this work, we investigated 4 distinct methods of linking before settling on a hierarchical deterministic approach. This method performed as well as the probabilistic matching software LinkSolve, while being easily explained to our multidisciplinary stakeholders and computing efficiently. This efficiency of computing was critical given the size of the data sets that we were working to link. In North Carolina, we have over 800,000 people involved in motor vehicle crashes each year with potential injury, approximately 5 million emergency department visits a year, and about 1.5 million EMS runs. So when we're running even just a year's worth of data to link, we're looking at a lot of records that have to be processed. The hierarchical deterministic approach was also readily adapted to other linkage applications, and we've used it on several other projects since developing it through this motor vehicle crash work. We did use a hand review process to create a gold standard data set for linked crash report and death certificates, but this was simply not feasible on a large scale for the other data sources just because of the large number of records that were being processed. But we were able to use that gold standard linked data set to then measure the effectiveness of the different linkage methods that we were evaluating. And that helped us determine which one to go with moving forward. It was clear from the beginning that people wanted to be able to access and use the linked data through NCSIS. But because health data are heavily protected by their data owners, it can be difficult to make data available publicly. We created a dashboard that provides aggregated data to users, including telling several specific stories using both linked and unlinked motor vehicle crash injury data from a variety of sources. And this data dashboard, because the data were aggregated, could be made publicly available. And I encourage you to have a look at the information on that dashboard if you get a chance. One of the focus areas for the dashboard is pedestrian injury, and I'm going to turn it over to Katie, who'll be telling you more about that now.
Thanks, Anna. Give me just 1 second while I share my screen. Okay, Anna, thank you for that informative overview of data linkage and for describing some of the benefits of linkage that we have experienced here in North Carolina. I'm now going to give some examples of how linking crash and health outcomes data can be used to answer important pedestrian and bicycle safety questions. In June 2019, the Collaborative Sciences Center for Road Safety funded a data linkage project inspired by the work led by Dr. Waller and myself to focus specifically on pedestrian and bicycle crash-related injuries. As one of our first activities, we compared the number of pedestrian and bicycle crash-related injuries observed in the crash data to the number observed in the emergency department visit data over a 5-year period in North Carolina. This figure displays one of our findings. In this figure, the horizontal axis displays the month of the pedestrian injury, and the vertical axis displays the average number of reported injuries per month, with the number of injuries reported in the crash data indicated by the dark blue line with circular markers, and the number of injuries observed in the emergency department visit data indicated by the lighter blue line with square markers. Although we found that the patterns observed in both data sets were nearly identical, for each month, on average, there were 90 additional pedestrian injuries reported in the emergency department visit data as compared to the crash data. While initially I was suspecting some differences in numbers of reported injuries across the two data sets, this was far more than what I had anticipated. However, the amount of underreporting observed in the crash data for pedestrian injuries was dwarfed by the amount of underreported observed for bicycle crash-related injuries, in which the North Carolina Emergency Department visit data reported nearly 600 more injuries per month among bicyclists as compared to the crash data. Much of this difference is definitional. Each emergency department visit data contains injuries related to falls from bicycles, while the crash data do not. In addition, the emergency department visit data includes injuries related to bicycles colliding with pedestrians or bicyclists colliding with other cyclists, and the crash data do not. However, these events are still important from an injury prevention and public health perspective. Regardless of the specific injury mechanism or whether or not a motor vehicle is involved, the built environment, along with other factors, including a lack of designated bike lanes, poor quality pavement, and site obstructions, contributes to bicycle crash-related injuries. So the next several slides will refer to the linked pedestrian crash and emergency department visit data. In our study, we matched approximately 50% of our pedestrian crash records to emergency department visit records. One of the primary reasons that we linked these data was to collect better information on injury outcomes. The crash data has a single variable indicating injury severity called CABCO. In the period under study, CABCO had 5 levels. K equals killed, A equals disabling injury, B equals evident injury, C equals possible injury, and O equals no injury. The problem with this metric is that it is assigned by police officers at the scene of a crash. Since most police officers are not trained healthcare providers and do not have access to diagnostic equipment, it is difficult for them to accurately assess injury severity, except for persons who have died. Previous studies have found that police officers tend to overestimate injury severity for bloody injuries, such as scalp lacerations, and they tend to underestimate the severity of injuries to the internal organs, which often can have no visible manifestations on the patient. In our study, we found that 50% of B evident injuries were actually serious injuries based on clinical information. And this is important because many transportation departments focus primarily on preventing K and A level injuries. Now that we have an indicator of injury severity using clinical measures, we can better describe the relationship between certain factors and injury severity, such as identifying specific groups who are more at risk of serious injuries. In our study of pedestrian injuries in North Carolina, we found that young children and older adults were more likely to sustain serious injuries after being struck by motor vehicles than working age adults. Another benefit of linking crash data to emergency department visit data is that we get access to more variables and we are able to dig a little deeper into the data to better understand why certain groups are more at risk of serious injuries. One observation that we were able to make was that 39% of child pedestrians were diagnosed with head injuries, as compared to only 24% of adults 25 to 44 years of age. We are now actually receiving funding from the North Carolina Safe Routes to School to examine child pedestrian injuries a little bit more closely. In addition to children, we also found that male pedestrians and pedestrians struck at higher speeds were also more likely to have head injuries. One of the reasons that we looked at head injuries is that they tend to be more serious than injuries to other body locations and can have debilitating long-term consequences. These examples are just a snapshot of what you can do with multiple data sources, both linked and unlinked. please check out the full report and accompanying slide deck on the CSCRS website. We will share a link in the chat to this report. So now we're going to discuss some of the challenges that we faced during our years building a data linkage system in North Carolina. We've organized our challenges around 3 themes: stakeholders, funding, and technical challenges. Note that this is not an exhaustive list of challenges because that could take up an entire presentation. Over the course of the next several slides, I'll hit some of the main challenges and then have Anna fill in any challenges that I may have to linkage that I may have missed. So I'll start with challenges related to engaging stakeholders. Well, we found that working with a diverse coalition of stakeholders to be a rewarding experience and fundamental to any data linkage project, we also faced a number of challenges. We found that despite our best efforts, over multiple years, we were unable to engage everyone that we thought should be at the data linkage table in North Carolina. Our lesson learned from this challenge is that at some point, you must accept that this is going to be the case and move on, or at least move on until there has been a change in personnel. Another challenge that we faced is that obtaining stakeholder support is just the beginning. It also can be quite difficult to keep stakeholders engaged. Data linkage, especially in the initial steps, can be rather boring. This is when you're attaining data use agreements and obtaining data sets, and there's not necessarily a lot to show to your stakeholders. Therefore, to maintain engagement, we held annual stakeholder meetings along with content-driven presentations, fact sheets, and short reports. However, it's important to walk a tightrope between keeping stakeholders engaged and wearing out your welcome. Also, we found that just because a stakeholder expressed verbal support for a project, it did not necessarily translate to more tangible support, such as attending meetings, evaluating products, sharing data, or providing funding. And finally, we found that having multiple stakeholders resulted in a lack of ownership of the system on the part of the stakeholders. As an example, when we were building our data dashboard, we couldn't find anyone willing to host our dashboard on their website. This was somewhat frustrating because while we wanted credit for our work, we also realized that our dashboard might get more traction on a more heavily trafficked website. Anna, is there anything else you'd like to add regarding stakeholder support?
Thanks, Katie. I think the only other thing I'd point out is that, that kind of builds on this is that we had a large stakeholder group that met regularly and that we kept updated regularly, and that was great. But in the last year of our work, we actually created a smaller advisory group that was made up of people who had gotten more engaged in what we were doing. And we had working meetings with them where they really helped us hash through some of what we needed to do, particularly related to the design and build of the public-facing dashboard. And so that smaller working group of advisors was a really important piece that we eventually came to. Thanks.
Thanks, Anna. That's a really great point. The working group was very helpful in moving forward with our dashboard. So now we'll move on to challenges related to funding. And to be fully transparent, finding funding has been our primary challenge. We are currently not funded to link crash and health outcomes data, and therefore we are not linking data, although we still are obtaining data sets, and so we're ready to go if any funding opportunities come to us. Large data linkage systems are not conducive to annual, low-budget proof of concept proposals. To operate a successful data linkage program, you need support for program management, you need support for technical staff, you need support for obtaining and linking data sets, for system maintenance, for enhancing the dashboard experience, and examining specific research questions, as well as support for disseminating data. One of the lessons learned from our experience, I think many states found this to be the same during the NHTSA funded codes program about 10 years ago, was that some states are unable or unwilling to pay for data linkage, especially data linkage beyond a single research project. Certainly that's unfortunately been our experience in North Carolina. Anna, anything else that you would like to add?
I think you summed it up really well, Katie. I think often funders are looking to fund specific projects that use linked data, but without an ongoing system to create the data integration, the data aren't there, the linked data don't exist to build those projects on. And I think we're sort of missing that foundational piece of needing to have an ongoing data integration system so that it's there to build specific projects around.
Yeah, that's a good point. So funding is not our only challenge. We also encountered numerous technical issues as part of our data linkage project. And one such issue that we encountered was related to data acquisition. It can take us months to work out our data use agreements, which we have to do every year. Also, it takes a lot of effort to link large data sets, and even a small change to a data set structure or a change to the methodology can result in hours of work on the part of our skilled statisticians. Even if our no changes are made, we just run the same code from last year, it still takes a considerable amount of time to clean and link the data because of the size of the data sets, especially some of the healthcare data sets. And as you add additional years of data, it becomes even more complex. Another problem that we have faced is related to health data protections. And Anna touched on this a little bit in her part of the presentation. Anna and I both come from a public health background, so we are used to using aggregate population-based data sets. However, transportation safety professionals often like to have data at a more granular level, such as the corridor level or the site level. We are still working on a way to provide transportation safety practitioners the level of detail that they need while protecting patient information and abiding by the terms of our data use agreements. However, we have not yet found a solution to this problem. So if you have any suggestions, please put those in the Q&A. Anna, are there any more challenges that you would like to mention related to technical issues or otherwise?
No, I think you've covered it really well, Katie. I mean, I think one of the things we were really trying to accomplish with NCSIS and with our data dashboard was creating that ability to provide data to any and all users, but in a format that we could get around a lot of the data protection issues. They can be frustrating, but coming from the public health side, we really understand the importance of protecting health data, and it is possible to share health data. It's not totally impossible. You just have to do it with aggregation and making sure that there's no way that people can be identified deductively through what's being presented.
Yeah, no, and I think we could do a lot more interesting things with our dashboard with additional support. It's quite impressive, but it still has ways to go. And I think we have hopefully some things we can explore in the future. So despite these challenges, data linkage is still worth doing, and for the following reasons. It provides an opportunity to build relationships across organizations, to improve data quality, to improve technical capacity, to characterize the burden of pedestrian bicycle crash injury over multiple data sources, to evaluate programs and policies, to educate decision makers and the public, and to address issues around equity. Certainly more than we can do with only looking at the crash data. So that concludes our presentation. We will put our contact information in the chat, and we will now take your questions and comments.
All right, thank you. We've got a few minutes left for Q&A. So I wanted to go through some of the ones we've received, and there's still some more coming in. So Katie, one of the questions was to ask if you could clarify again what your definition, as part of this study, what your definition of serious injuries was and how that's defined.
It's a very long definition, and so I'm not going to go through it in its entirety. It's available in the report as well as the accompanying slide deck, but it's based on the NTSB definition of serious injury. So it includes things like hospitalizations, second and third degree burns that cover a substantial portion of your body, certain types of fractures, that sort of thing. So it's based on the actual diagnoses as well as for people that are hospitalized.
Okay. Thank you for that. There's a person who's asking about what software you use to perform the linkage, for example, SAS or something of that nature, and ask if you have anything you could recommend for optimizing processing speed when working on linkage.
Anna, do you want to take that one?
Sure. We've actually used a variety of software approaches. I know Katie's done some things with SAS, and with the hierarchical deterministic approach, you can do that in SAS, and we have. But in the end, we ended up setting up the process in R because it just was more efficient way more efficient than SAS and ran much faster, and also had a lot more flexibility in terms of adding additional layers of the passes through the data for linkage. One of our colleagues, Dr. Mike Fliss, is an R expert. Neither Katie nor I would have been able to do it in R on our own, but luckily it gets back to having that good multidisciplinary project team with a lot of different skill sets. And so, he was able to build that in R for us.
Yeah, I can attest that doing it in SAS is extremely challenging, and I would not recommend it. One thing that we're finding out now is because even with R and a fairly powerful computer, it's still taking Dr. Fliss quite a long time. We're talking order of a day to link these data sets over multiple years. And so we're having to break it up into chunks, which is not particularly efficient. And so we're still trying to figure out ways to potentially use someone else's computer or something like that that's a bit more powerful to get around some of these challenges, because it's, quite disruptive to your day if all you can work on is just running data linkage in the background while you're doing other things, which you often can't do.
There's another question here of asking if you've used GIS to find spatial patterns in your linked data set. This person says the most difficult data set to collect has been ambulance incident response locations. And they use the location data provided by ambulance companies to plot where these injuries have been, but it seems like that may be a challenge. I don't know how you've been able to deal with the spatial analysis portion of this.
You want to take that one, Katie?
Sure, yeah. Most of the data we've worked with don't have any spatial components on the healthcare data side. So our emergency department visit data, our claims data, our hospital discharge data, they don't have anything related to where the person was injured. We have used EMS data in the past, but it wasn't a very high quality linkage. It was something that EMS had done several years ago. It'd be something that would be interested in looking at the future, because that is one of the things that is very beneficial about the EMS data, is they also have location of incidents. So it can hypothetically make linkage a little easier between the crash data and the EMS data. And maybe through linking to the EMS data, then you can easily link to, say, the emergency department data or the trauma registry data, but it's not something we've had the opportunity to pursue.
A question here asking if you think that privacy is a bigger challenge for this effort, particularly if media reported crash data is linked with data that is more private. They see this as one of the biggest barriers unless you're getting into really very aggregated analysis, media issues being a big window into triangulating that disaggregate data. So I don't know if you have any response to that.
Well, we have not worked with any of the media reported data. I'm not sure I'm understanding the question entirely, but there's certainly, and this actually ties into some of the question about geographic location. We can get very specific geographic location from the crash report. But as Katie said, we generally don't have that except in the EMS data, and then it's been spotty, at least for us in North Carolina. But once you get into very detailed location, it gets much easier. If you've also got basic demographics and timing, deductive identification of the patient becomes a real risk. And so, yeah, I think we have to do things with aggregation or with fuzziness around location so that you're not pinpointing exactly where things happened. But yeah, I do think that privacy is a big issue with these data.
Well, thank you for that. I'm sorry to say that we'll have to end the discussion there. There were quite a few questions that came in. I apologize if we didn't get to yours. We did provide in the slides, which will be coming, and you can track us down through the webinar information, some contact information. You can reach out to us if you still have those questions. We can hopefully connect you to the right folks to get them answered. But I just want to give a big thanks again to Dr. Katie Harmon and Dr. Anna Waller for sharing their work today. And thanks to you all for being here. Please attend our next webinar, look for information on that, and look forward to the recording and the slides coming to you a little bit later. So thanks, everyone. Enjoy your day.